I'm Mike, specialist nurse in neuroendocrine cancer in Oxford, and have been doing that role now for 13 years and helped set the service up in Oxford. I've got a particular interest in how patients make decisions and how we as clinical teams support patients to make decisions in clinic. It's a complex area. There's lots of research into it. It's a difficult area. It's something I think we always need to work on and improve. So I shall hopefully give you a little bit of a whistle-stop tour of some ideas, a few case studies of work, of stuff we've done with patients, sort of some examples in our clinical practice, and then always most interestingly is to open it up to questions and sort of get a bit of a discussion going. The talk's going to capture some of the challenges inherent in treatment decision-making. I'm quite interested in the role of the cancer MDT in decision-making. We often talk about the MDT and have lots of patients saying, what did the MDT decide? So I've got a bit of look at that. And there's some key issues around uncertainty, as I think that's an essential part that we need to cover. And then the role of shared decision-making and acknowledging uncertainties. Those are kind of the key areas that I'm going to focus on. So clearly, with cancer treatment decisions are inherently stressful. A cancer diagnosis, I'm going to consider what treatments I might need, whether one's better than another, what side effects. It makes it an inherently stressful situation. Often it's a new situation for people. They're recently dealing with a recent diagnosis. They're starting to try and understand their illness and the implications of it. And then this complex decision of what should I do now? It's getting harder as well as treatment options increase. And there's obviously a built-in uncertainty and emotional challenge to cancer treatments. So most cancer treatments don't give 100% response or zero response. They give something in the middle. So there's this level of uncertainty. How will I do on this treatment? It can also be really hard to balance the benefits and the harms. So, what will the toxicity be like? I may have a huge list of toxicities from a chemotherapy or, a radiotherapy treatment or surgery, but will they apply to me? What does 20% chance mean? What does this mean? How does it really look? What's it likely to look like? How am I likely to respond to it? What will my symptom-free survival be? What will my overall survival be? How will it impact on that? And of course, the impact on my function, my everyday life, and my quality of life. So there's so much going into it. And actually, when we try and make decisions in stressful situations, really it's easy to think that we're sort of rational human beings and we all make rational decisions. But of course, actually, even the most simple decisions we make in life are sometimes inconsistent and involve our own biases. So it'll be based on things that we experienced in our own life. Experiences we've had, people we know, good friends who come to tell us, like, this happened to me, or my consultant said this from a support group. All sorts of things will impact on how we end up making our decisions. And to make decisions, therefore, we often use these sort of mental shortcuts. So, for example, only last week in clinic, someone said to me, well, I'm never going to have chemotherapy. Like, my mum had chemotherapy and it was a disaster. And is that like, okay, that's a kind of place to start. And how do we then work? How do we work with that person to help think about, does that apply to them? How do we work with that value, that personal experience? So we've got cognition, sort of thinking, we've got our emotion, we've got all the personal social values, and they're all providing different ways of viewing information. And actually, when we're making cancer treatment decisions, of course, we're trying to really think of the future. How will this impact me in the future? And actually, most research suggests we're actually it's quite difficult, and we're not very good at forecasting how will we be in the future. It's quite difficult enough to know how we might be tomorrow and the things that impact, but so how are we going to be in the long-term future? So we're trying to make decisions that are very future-based without really knowing how we'll be and what our thoughts will be in the future. And then when we look at the other side, the sort of doctor's side, the other person in the room, so the doctor, the nurse, there's the patient. Actually, studies tend to show that despite the decision really being for the patient and should be working for the patient, that the doctor's preference is often what determines treatment rather than the patient's preference. And this is based on a whole load of research around all sorts of areas. So classic examples such as tonsillectomy. So we know that if you look across the United States at different states, that rates of tonsillectomy are widely different, not because population varies, but because practice varies in those. So people within their own sort of areas of practice, with their own communities, will tend to practice more similarly to doctors and or teams across there. We know that antibiotic use variation, though improving, still there's like twofold variation in antibiotic use across GP surgeries in the UK in different regions, and sevenfold variation in the use of certain antibiotics such as cephalosporins, which again isn't based on the population, but is clearly about medical preference in those areas and practice in those areas. So going to your GP and saying, what's best for me, do what's best for me, actually varies, because if you're in one area, you're more likely to be given an antibiotic, and in another area, you're less likely to, for the same situation. So we know this varies in these areas, and therefore we know that preference in cancer treatments will vary across clinicians, will vary across teams, and will vary, can vary widely. So this is all coming into the challenge of what's the right decision. And then further research will tend to show that actually both patients and clinicians tend to overestimate intervention benefits. So if I give you this treatment, these are the benefits, but also to underestimate the downside. And this has been looked at in all sorts of areas, whether it's benefits of screening, whether it's the benefits of certain chemotherapy, and also in some studies, which I'm not really going to focus on in this talk, more end of life and prognosis, where again, estimates of these things tend to be overly optimistic. So the accurate information isn't necessarily always coming into that room. Finally, furthermore, we know from studies that actually many clinicians, and when I say clinicians, I'm not just meaning doctors, and we'll talk about nurses and other health professionals as well, often avoid difficult conversations such as prognosis. So though they may discuss it, there's often vagueness to it, and rather than people not liking to be brought down to specific information and detailed information, so it's often talked in rather vague terms. And there's studies that support that, study where I looked about 70% of patients who wanted accurate prognosis, about 19% of them actually felt that they were given information that was helpful and useful in that situation. Then one of the other challenges is both our thinking and our emotion conflict. So we might see the data in front of us, but obviously the emotional impact of that is really, really strong. Classic examples there are another cancer that is often described as potentially slow-growing is prostate cancer. And so a number of men will be diagnosed with early prostate cancer and will then go to meet their oncology or urology team, and we'll be given the choice often between watchful waiting or active surveillance, so some form of PSA testing or screening, versus surgery or radiotherapy. And the implications of surgery and radiotherapy in this settings are quite severe. Risks of incontinence and impotence. Actually, statistically, for many men, those three options are identical in terms of likely outcome. But we know that without shared decision-making with decision-making aids, a significant majority of men will go for treatment, which is clearly around the emotional impact of considering what happens if I don't have treatment. So there's a sort of drive towards the treatment based on that emotional fear of cancer progressing, and maybe sometimes in some of the studies showing a limited real understanding of the downside of treatments. And in a neuroendocrine setting, that's quite common. We see that with small pancreatic neuroendocrine tumors, so where people will have small tumor, less than 2 centimeters in the pancreas, which completely asymptomatically, often found incidentally. And then the discussion on what should we do about that? Should it be removed? Should it be what? Should it be left alone? And the implications of pancreatic surgery, again, are quite severe. And I've got a couple of cases later on looking at that. And then when you are given quantitative information, so numbers and percentages, actually, they're often really difficult to make sense of. What do they really mean? What does a 10% improvement mean? What does an overall response rate mean? So it's the actual, so for some people, they may deal with quantitative information very well, but many people struggle to really understand it. And of course, a number might be the same. So I'm planning a barbecue on Saturday, 20% risk of rain. Feels like a pretty low risk to me. I'm happy to plan the barbecue. Or 20% risk of developing cancer, well, that feels like a really high risk to me. So the number's the same, but of course the context is everything. The implications if it rains is the barbecue's not so good, but I can deal with that. So I estimate the risk in a completely different way. So one of the massive changes in cancer in the many years that I've been a cancer nurse was the development of the MDT, the multidisciplinary team. And when I remember nursing before, multidisciplinary teams. So, and it all developed from this very famous Kalman-Hein report. There was the look at, the cancer report, and showing that really essentially in cancer care, there was huge variation, not only across regions and postcodes, but actually even within same hospitals, depending on consultants' preference. And this led to lots of things like the development of cancer nurse specialists, for example. So all our rules essentially stemmed from the Kalman-Hein report. It's led to significant improvements in staging of cancer, adherence to guidelines, recruitment to trials, use of evidence in practice, timeliness of care, and also access to allied members of the healthcare team. So there's been significant improvements in cancer care since the Kalman-Hein report. And one of the things that came out was MDTs. All cases are discussed in an MDT. And though there wasn't a specific guidance around neuroendocrine cancer in that, we've tended to try and model that practice in practice. So we have a cancer MDT in Oxford, and most specialist centres will all have that, where cases are discussed with a whole range of experts. Of course, the key person that's typically missing in the MDT is the patient. So, and I'm not going to discuss how we could make that work today, but it's a really huge topic. Sometimes there's a sort of concept of surrogacy, that the nurse is their advocate, or the doctor is their advocate, or someone's their advocate. But the reality is that actually, even if I know my patients very well, I'm not able to put their point of view across in a meeting. I can say what I know and guide things, but that one person's clearly missing. So MDTs tend to sort of create this best patient decision. And really, when research has looked at this, but also my own practice, that that seems to be the aim of most MDTs, is everyone gets together, they have a big chat, and they look at scans and look at pathology and do all this stuff. And then they come up with a sort of, this is the decision we make. And it's normally in terms of the treatment. Theory is the best treatment response, best overall survival. So that's the kind of concept that MDTs work on. And then what really happens then is the patient then comes to a clinic, and that's presented to the patient as a best decision. But what's often missing, and I'm not saying always, but is that actually there's a lot of uncertainty often inherent in these discussions. So what doesn't necessarily come across is the fact that there were several options. There were a whole range of options that were discussed, and the differences between those options aren't always captured in clinic. And as I say, this has been looked at most recently in head and neck cancer, where doctors who'd received these MDT discussions felt that their job was to present that MDT best opinion rather than to talk through the complex nuances that were involved in that initial discussion that led to that decision. And then, of course, the discussion in the MDT hasn't really involved what the patient's priority was, what their values were, what their aspects of what they felt was most important. So, for example, there's an assumption that if our MDTs are looking at what the best outcome is in terms of overall outcome in terms of survival, then that doesn't necessarily fit always what some patients want. Some treatments, the side effect profile of that treatment may be something that patient doesn't really want to think about, doesn't really want to go down that line. They may want to go down a very different line. And there's some assumption there for the doctors, the same values as the patient to establish what's best, but we know very clearly that is not necessarily true. And as I say, doctors may see the MDT decision as set in stone and obligatory, and that they have to present that to patients. So there's a chance of though MDTs are amazing and doing lots of things, one of the things that has happened from them that can sort of encourage that move back to a slightly paternalistic medicine where information is given to patients that this is the best thing to do. And then we come to neuroendocrine tumors, neuroendocrine cancer. So what are the decision-making issues that come across in clinics here? So one of the challenges have that actually in neuroendocrine cancer, we lack a lot of high-quality research and study exploring treatments. And we have a limited amount of studies that directly compare known treatments, which makes it even harder because the evidence that we're presenting in clinics is a little more hazy. It's not always as strong. And it's when you look at these studies, often they have quite what we call heterogeneous samples, so a real mix of grades of tumor cancers, different levels of metastatic disease, of small or wide, and therefore trying to work out what the result of that study means to you sitting in a clinic, or even for the doctor or nurse to make out how does this trial really apply to you in real life is quite challenging. We have international guidelines and they're really helpful. And again, they help us kind of standardize practice and standardize approaches, but they can be rather broad and a little vague at times. And then, of course, not everyone. I mean, I'm lucky I work in one of the cancer centers of excellence, and many patients will have links to cancer centers of excellence, but not everyone does. So again, they may be missing that access to specific expert teams who understand these cancers. So from all what I've said there's a real level of uncertainty in evidence, and consequently what might constitute the best treatment decision isn't always in black and white as it sometimes is presented, or might, be expected from someone with cancer, where they expect there's a sort of really straightforward, this is what I must do. So the decisions are often more nuanced, the evidence is more nuanced. So that uncertainty can be very challenging, but it obviously needs to be managed, and that's the role of that conversation in clinic and that work that we should do with patients when they do come into a clinic to meet us to talk about what treatment should we do. So I've just got a little look here as, for example, I mentioned that guidelines can be helpful, and here's a lovely algorithm of what we should do for people with pancreatic neuroendocrine tumors, and this is from the European Society of Medical Oncology guidelines, the 2020 guidelines. And this is kind of going from top to bottom, is looking at different grades of neuroendocrine tumor and what should be the sort of treatment options as we go down that route, as in first line, second line, third line, so on as we go down. And as you can see, there are some areas where there's given a very sort of fairly straightforward guide, to give a somatostatin analog. But there are areas where actually the option given to clinician is 4 options. You can see there again and there. So it's not actually saying there's one best treatment, because there are actually 4 very different treatments mentioned there that could be the best treatment for you sitting in the clinic. So you can see that even with well thought through research guidance, that actually choices are complex and by definition uncertain. So how to make this better, how to improve this, how to work for that? And really, I think the focus I want to work on the rest of the talk, and then when we discuss things later, is this concept of shared decision making. And also that it's really important that we acknowledge uncertainty and ways to manage uncertainty. And there's a quote there from William Osler, who in Oxford, there's one of the big medical buildings is named after William Osler, and that concept of the science of uncertainty and the art of probability, and how to work with the reality of this. So there are an increasing number of ways that we can work towards improved decision making in clinics. And all the studies show, and I feel not just in research, but in practice over so many years, I've seen that real shift from sort of people telling people what they're going to do to them, and what, to a much more collegiate approach in clinics. And it's something, I've seen it both in oncology, I've seen it, in endocrinology, and right through nursing, that real significant change. But so an increasing number of patients prefer involvement in decision making, whatever that means. It can mean a range of things. But there's not always congruence between clinicians and patient preferences. So, even when you look at studies more recently, there will be a number of patients who still really like to take a passive role and really sort of there is like, I'm here because you're the expert. You tell me what to do. That's actually my most comfortable position at this moment. Clearly, there's people who want to be fully involved with all the information and looking for second opinions and going to the internet and going to support groups and charities and really wanted to come in with full information and be very, involved in that decision making and take a very, very strong role. And because what works is when there's congruence, when the team have the flexibility to work with different people and their different needs and to do that flexibly. So it's not about taking a similar approach with all patients. I'm going to give everyone who wants PRT, I'm going to give them all the same information. I'm going to do it in exactly the same way. And you're not going to stop me. And, I think over the years, I have worked with clinicians who, that's it. This is how I tell people, Mike. This is how I tell them about this treatment. Okay, well, kind of that worked for him, but I'm not sure it's really working here. So that kind of flexibility. And we all have to do that. We have to move, change in our approach in different situations. Professionals need to be able to assess and respond to patient preference values. So that assessment is key. How is it you want information given? How is it you want us to discuss this? How can I help you come to a decision here? Are you wanting me to go through this in detail? Are you wanting a little bit now and we'll do a bit later? And one of the other ways that can help is some decision aids that can help shared decision making. So I won't spend long on decision aids, but there are a whole range of things out there. Unfortunately, not specific ones really within the world of neuroendocrine cancer that I know about, but there are ways to support patients to make decisions in neuroendocrine cancer that, whether it's patient information list of questions that I know Nikki and the team have created, obviously information and videos that Neuroendocrine Cancer UK have, all those sort of things help patients, with decision making and being more involved in the clinical room. But some of these are more specific tools. So risk calculators, I'll show you one of these in a second, online information tools, videos that highlight very detailed statistics on decisions. So there's, for example, there's ones around prostate cancer screening, there's ones around breast cancer treatment, early breast cancer treatment, and decision to have adjuvant chemotherapy or not. So there's a whole range of things out there. And the idea of them, and most research provides it, it helps patients feel informed, which again, charities like NC UK clearly do. It helps them get more accurate risk perceptions. So information on, say, for example, the risk of prostate cancer treatments, risks around impotence or incontinence, and then the risks and benefits of taking a watchful waiting approach. If they're sort of lined up against each other in a document, it helps patients start to get a sense of what the real risks and benefits are. And it also helps patients take an active role in decision-making. And also from a quality of life or sort of anxiety point of view, the people tend to feel less decisional conflict. And it feels that also they're able to express their own values more clearly. And a number of the tools do ask you to put down what are your values, what are your preferences, what's most important to you. So I'll give you an example of an online risk calculator. And I mean, this is meant to make things easier. But you can see it's quite complex by itself. But so what this is doing is the top line. So this is someone who would have had surgery for breast cancer. And the top line is showing that if we do nothing else, what will happen? And it's saying that essentially in 10 years, 75 people would still be alive and without cancer. 20 and a bit people would have relapsed, and 4 and a bit people, and that's the blue is the same on all of them. So over that 10-year period, 4 people would have died of another cause. And then what they're showing is if you add in what were called adjuvant treatment, so this is someone who's had surgery that to all intents and purposes, the disease has been removed. And this is what we call adjuvant therapy. So this is where if you add in hormonal therapy, then you get another 10.8 people don't relapse. So that's the improvement. And it's done as that yellow. You can see the yellow bit there. What does chemotherapy add in? It adds in overall about 4.4. And then combined, if you do both, it improves the outcome for about 13 people. So 13 out of the 20 would have relapsed. In theory, now wouldn't relapse in a population. Okay. So this is trying to establish or to explain, to show patients in some sort of graphical way how their adjuvant chemotherapy may improve their outlook. As I say, without the huge trials that you have, say, in breast cancer and neuroendocrine cancer, it's very hard to provide that sort of detailed information in a clinic in neuroendocrine cancer. But people can still look at studies and statistics and try and support patients to understand what each type of treatment may add in. So essentially, if you're going to have shared decision-making, the bare minimum that you can have is you must have a full understanding of the benefits. So people must be able to explain what is this treatment going to add? What's the potential of this treatment? What may it help? How may it help in terms of symptom management, in terms of improving survival, etc. You must also have a full summary and likelihood of harms, and someone trying to explain what that means in kind of real bottom lines of terms. And then, of course, the uncertainties associated with each and alternative courses of action, so that you're aware of how likely the benefits or not are to come. And of course, all of this should be compared with patient values, their preferences, goals, and priorities. So as you can see, you're not going to do this quickly. No one's going to do this quickly in a room. This takes time. It takes getting to know people, and it takes creating an environment where patients feel comfortable to share those values and preferences, but are also asked openly about them. So they're not seen as an add-on, but they're seen as integral to the decision. And that's a key in how consultations need to run to allow that to happen. And just to give an example of how this might happen, so there's been a study which was looking at, I think it's in Australia, where patients were given a whole range of documentation to allow them to prepare for their clinics, and encouraged to ask questions and given advice about how decision-making is made and how consultations run and their rights, and to ask questions and to ask certain opinions and so on and so on. And then in the study, they looked at what happened in the room with the clinicians. So these were clinicians who were already sort of up for this and keen to be involved in shared decision-making. And fairly good treatment choice, explicit treatment recommendations, and patients' preferences acknowledged were in about 3/4 of the encounters. So it's not perfect. It should be better to be 100%, but it's there. But then when you look further, actually the evidence base and acknowledged uncertainty evidence was based in a far smaller group of encounters. And actually they acknowledge differences in opinions, that there may be a variance in opinions, and the quality of evidence, how good is evidence, was actually only discussed in around 1 in 7, 1 in 8 of the consultations. So this was a prepared group, and yet key things were missing in the decision-making context. So most studies show that the uncertainties in making decisions are not directly dealt with, despite them being inherent in everything we do in healthcare. Lack of evidence is rarely openly discussed. treatment options are often presented as a single data point. So it's very, it's not unusual for people when they do ask about, either overall survival from prognosis or overall benefits of a treatment are often quoted as, and I've picked one from, say, there were two studies that famously came out a good number of years ago now that looked at sunitinib and everolimus, and the key message that came from those was this 11 months median progression-free survival. So, and that was compared with typically not having that treatment around about 4.4 months, something like that. So it sort of added 7 months progression-free survival. In a later step, I'm going to show why I think that's a really unhelpful statistic given as a single figure. There's a lot of data within that doesn't get discussed. As mentioned already, MDT outcomes are often presented as single best option. And again, in the next slide or a couple of slides on, I'm going to talk about the skewed nature of research evidence. So how actually, when you look at survival curves, there's a lot more information that could be shared much more helpfully than just giving this one sort of figure. And I think I've mentioned already about this, often overestimating prognosis and not necessarily meeting patient preferences for information on prognosis. So this is a slide I want to spend a bit of time on. So the title isn't mine, the median isn't the message. That comes from a really famous evolutionary biologist, Stephen Jay Gould, who was diagnosed with, I believe, mesothelioma many years before his death. And he was given the information in the clinic room that his median survival was about 9 months, 10 months, something along that line. And this message is used again in a recent study from Norway, where the lead person in the study was given a similar message in clinic a few years ago with a different cancer, where he was given this fixed median point. And when he asked more information about that, the doctor got very hesitant and was, well, you might be better, it might be worse, but didn't really go much more into it. And so this curve, so what this really shows is that, so the median point is where 50% of people have survived, are going to survive beyond that, and 50% of the people have died to that point. And this is a curve from people with quite high-grade neuroendocrine cancer having PRRT. So the median point is kind of here. And so that's where 50% on this line show. And if you sort of take that down below, you'll see in months that comes to about 19.9 months, it says. So you can see it's very close to the 20. But what happens to this curve is actually, if you follow it down, it goes out a really long way. So, and this is typical of most cancer survival curves and treatment curves, is that there's this, what we call this right skew. So the left-hand bit's quite squashed in. It's the right-hand bit beyond median goes out for a long way. Yeah. And as you see, it gets out to the 120 and it's still not got down to 0. So this figure of 19.9 months, which many people might see the average survival, actually, a third of the patients are still alive at 3 years. 20% of the patients are still alive at 5 years. And 10% of the patients are still alive in 8 years, and some go out further. So actually this 18 months, 19 months, this less than 2 years point doesn't really describe all of the potential hope in here for people who respond well to treatment. And Stephen Jay Gould he's written a lovely bit, and I'd be happy to give you the direct reference for it, Nikki. It's just I think it's one of the best things I've read by a really good thinker and writer about the real disaster of this, the median just being given as a useful figure, when actually it's very clear that there's a lot more information here that is very helpful for people to think about how do they respond to treatment, how may they respond, what's the hope that's in this work, that actually if you are a good responder, this curve drifts out a long way. And in neuroendocrine cancer, that's certainly the way. When you look at the survival curves of low-grade neuroendocrine cancer, they have huge right skews to them. They go out a long way. And I think that's a really important message. It doesn't mean that the rest of the message, oh, sorry, I'll go back, isn't important as well. And so it's not about giving people false messages, but it's about explaining, it's about giving more information, more useful information for people to try and make sense of what this really means rather than this one figure. And I'm sure Nikki would remember, I mean, how many patients have we met over time who will say something, the doctor said, I've got, and then quotes a figure. And you're like, oh, did they? Not sure why, or, and actually it's not helpful. We know it's not necessarily a helpful thing. And it fixes a time point when you actually look at that curve. The time point isn't really any more relevant than many other time points you could pick on that curve and discuss in a different way. I know that's quite detailed. Maybe it's not quite expected out, but I think it's a really important message when we think of trying to get information from our teams and working with our teams for more information. So a few little case studies just to kind of summarize some of this stuff in a different way, just to give you some real examples of work we've done in clinic recently. So 65-year-old gentleman, he had low-grade neuroendocrine tumor, he'd had surgery, and he had a few lymph nodes left. He had an oxytide scan at that time. We'd probably do a gallium scan now, but an oxytide scan, the disease lit up. He was clinically well. We recommended, or I'd say the MDT probably recommended, that he start on a somatostatin analog injection. He didn't like it at all. He started on the somatostatin analog injection. He got the worst gut symptoms. He could access PERT in those days quite straightforwardly. So he had Creon and he tried Nutrilime, and no doses of it helped, no response and changes of SSA, dose changes. And essentially, after about 9 months, he really just felt that it was massively impacting on his quality of life. So he couldn't play golf, he couldn't go on the sort of holidays he loved. So we met on about 3 occasions, a couple of times on the phone, once face-to-face, and discussed, do we stop your SSA? Do we, what's the risks for that? What's the pros and cons of that? And in a sense, in the long run, we acknowledged the limitations of the evidence. It was hard for us to give him really strong steer one way or other. But actually what I had to focus on, what were his concerns, what were his main values, what were his short and long-term aims. So we had a long open discussions. I mean, this wasn't one discussion. This was over probably 2 or 3 months where we met and created that environment that he didn't feel he was going against our advice just because we'd said, you need to start an SSA. We weren't now saying, well, you can't stop an SSA. We were saying, look, this is a reasonable thing to do. And we worked with that reasonableness that, we'll still scan you. We're still going to keep an eye on things. And essentially, the great news is 7 years later, SSA free. He's also had stable disease. He loves playing golf, other than his knees have got a bit stiffer and as he's getting a bit older. He's not 65 now, but he goes on his holidays. He loves, he cycles, he does all the things that he can not have the problems he had on SSA. So I think that's a good example of what felt like a really challenging decision for him to start with, but became something that felt like a reasonable and safe decision and had a really good outcome. So that's one example of supporting someone to make a decision. And then this is one where I think it just captures, these are 2 quite recent cases of patients who turned up to our surgical clinic, essentially both with similar things, in the sense they've both got small pancreatic nets that the first one incidentally found, so patient A incidentally found, avid on a dotatate scan. His background was an extensive family history of cancer. And when he arrived at our centre, there'd also been quite a slow process in diagnosis. So he'd been through sort of about a 6-month kind of process of an initial scan and things taking a long time. So that had really increased anxiety, obviously. So arrived at our centre very distressed, very angry, but actually clinically completely fine, no symptoms whatsoever. And then that focus on how should this be managed? So he came in very determined that we were going to cut this out, and that's what we should do. And we should immediately, no more faffing around. I've been through these other hospitals. Your job is to chop this out. And so again, a lot of work working with where he was, where he's at, and trying to sort of go through, actually, there's a number of potential options here. And, yes, surgery is an option, but it's going to involve removing some of your pancreas and your spleen and so on. And so talking that through. There isn't a right answer to what he should do here, but what we were able to do over, again, 2 or 3 meetings, and I think we acknowledged the first meeting was really about him trying to trust our team, was we're not going to, again, go against your wish to have this surgery. We're not saying we won't surgically resect it, but we want to consider that there are different approaches here, several different approaches that may be better for you given your comorbidities, your age, and what you're doing. So we have, over about 4 months, moved to a position where he's currently comfortable with surveillance. And that's how, and I don't know if he'll remain there. I don't know. But he has the confidence that actually, as he said, look, if I come back and I really say I can't live with this idea of not having surgery, we've acknowledged that despite the challenges of that surgery and some of the downsides he may face, that we would be willing to operate. So I think, again, that's about working with his, his values, his views, his current position, not just going with it, but actually trying to work in a complex way with it, try and come out with it, what we feel is the best decision, but also acknowledge that in the end, it may be that for him, the right thing is surgery. And then the other one is someone with a small neuroendocrine tumor, but with MEN1, so she has a genetic inherited condition, which changes some of the views on how we should manage small tumors in the pancreas, because the risk of progression, but also the slow-growing nature of these normally, but the fact that there will be multiple tumors. But a history of her mum, also with MEN1, struggling following pancreatic surgery. And this person's got a currently good quality of life. And the tumor's now moved to size that we worry it may spread and it may cause metastases. And with MEN1, that's a really concerning thing when they get to a certain size, because pancreatic nets tend to be the most, the highest risk thing for these patients. So patient focused on, again, all the options available, a wide range of options. And, the fact that this person feels, sort of paralyzed, with that decision, and about making the wrong decision, and again, how we can help them. And again, it's not really, the focus of the talk isn't to say there's one decision they should come to. I think it's about how challenging decisions are in clinic and how we can work with that person to support them. And then the last one is just a little different, and this is about kind of working with someone how to, at a more progressive stage of the cancer, how to work with their quality of life. So this is a young lady on metastatic adrenal cortical cancer on mitotane, really struggles with side effects of mitotane when it's in the therapeutic range. There's a range you have to try, you're meant to try and get mitotane into in the blood levels. But when it gets to that range for her, she really struggles. She's the main carer for a young family. She wants to spend as much time with them. She also doesn't want anyone outside her close circle to know about her disease. So, the options are to continue therapeutic mitotane to try and get it into range, to try and manage the side effects. She could stop mitotane, so feel better, continue active surveillance, but there's a view her disease would probably progress more quickly. And then there's been this talk for about 2 years with her about, as the disease progresses, should she start chemotherapy? She really doesn't like the idea of chemotherapy. So using I'm just going to put all 3 up, shared decision model, and this is a theoretical model, which really talks about how you have to talk about the choices. So that's where you use your risk calculators, your information, your decision aids, the experts. Then you talk through with the patient their patient's goals and values, the things we've talked about, and then clarifying those goals and values and coming to a decision. So that's essentially what we did with this young lady. So we've talked through the risks and benefits of mitotane. She knows them well. She tends to manage her mitotane by not taking as much of it so that her levels drop, but she feels better. Not much evidence about whether she should do that or not, but that's one of the things she does. Seems fairly reasonable to me, because she gets a better quality of life. But obviously, we haven't got much data out about how people do on mitotane when they're not at level. She knows the response to chemotherapy. We've gone through that. We know there are some long-term responders. So we didn't just give this 20%. We actually looked at the curves. We looked at the data. We know big symptoms it causes. And one of them, it causes hair loss. And of course, then her idea of keeping her disease away from other people not knowing about it is sort of blown. So she's very worried about that. Obviously, if we do surveillance only, she doesn't have to come to hospital as much, but she's going to continue to progress. We then went through some of the options with her and what her key concerns were, what her key wishes were. And in the end, we came up with a plan. And it's quite a flexible plan. And it had a certain amount of risk involved in it, and it had a certain amount of anxiety, both from ourselves as the team. And that's actually, she's going to hold off from having chemotherapy despite her further disease progression. She's going to hold off for a minimum of 4 months. And that's all about, she wants to spend the summer doing all the things she wants to do. But we were able to talk through those risks with her, and we were able to give them this a feeling as a balanced risk and let her, encourage, work with her to do those key things. And I think that was a team working well together and agreeing that these are difficult decisions. And she knew, there were risks that disease could progress more quickly doing this, but actually what were her values? And we came to an agreed decision. And I'm really pleased to say that she remains really well and is planning to start chemotherapy after the school holidays when her children are back at school, and they get very good pastoral support there. So it's a decision that I think has been well made. So final points, I think we have to acknowledge there's a huge level of uncertainty with all treatment decisions. They're inherent within healthcare, so trying to pretend they're not isn't helpful. And actually, patients' values and preferences have to be an integral part of every treatment discussion. And if they're not, we're missing the key thing. So for you guys, get as much information as you feel will be helpful to you. That's really key. That's one key thing. And you've got nets, you've got the charity, you've got online, you've got specialist teams. There's so many ways people can gather information. That's helpful, but it's only one part of decision making. You can link up with that advocacy groups, as I say, like NCUK. You have time to make decisions. I think that's really important, that we don't rush into decisions when there is time, and that's so important. Ask for, have time for second consultation, take information away and think about it. Or I think our surgical team and NETs are very good at doing that, letting people have 2 free appointments while we work out, is surgery the right option? Can you record the consultation? Can you re-listen to it later with a partner and a friend? Can you go through it with someone else? Arranging that follow-up, as I say, with a nurse after, or again with a consultant, and make sure your values and preferences are considered. I think they should be without you having to push that, but I think it's really important that it's done. And then there's no decision without me, that actually you're the partner in that. And if we don't, as a team, understand your concerns properly, then we can't make the right decisions with you. And what's really important, and I've just left it right at the very end, but second opinions, they're so important. And when we have rare-ish cancer, I don't like the word rare cancer, but cancers that aren't as common, that when we have cancers where levels of evidence, and as you saw in the guidelines, options are varied, there are several different options often. It's really important that if you feel you would like a second opinion, that you feel free to feel able to do that. And as a specialist team, we should be able to support you with that. GPs can support you with it. But I think it's something we shouldn't feel, as teams, we shouldn't feel worried that someone might want a second opinion. We shouldn't be offended by it. We shouldn't be upset by it in any ways. And I would hope other specialist teams feel the same as well. I'm sure most of them, they do. But that's where I think certainly we're very comfortable. We're often the second opinion, actually, but so we should be very comfortable the other way around when people who work with our team seek second opinions elsewhere.